Welcome to Therapy Cafe, the Future of Mental Health, Episode 9, Strengthening Young Brains, CBT for Children with Anxiety and OCD, with our guests, Dr. Mona Potter and Dr. Kathryn Boger. Today, we're tackling another critical issue, anxiety, the most common mental health disorder among youth and the challenges in accessing effective care. We'll explore evidence-based treatments for anxiety and OCD in children and adolescents, including cognitive behavioral therapy and exposure therapy. We'll discuss the vital roles of family and school involvement in care, as well as the use of medication. Dr. Potter and Dr. Boger are incredibly insightful in this conversation on how we can better support our youth facing these challenges. At the end of the podcast, we'll provide information about how you can obtain continuing education for this course. Also, ensure you never miss an episode by hitting the subscribe button. Here's my conversation with Drs. Potter and Boger. Hey, everybody. Welcome back to another episode of Therapy Cafe, the future of mental health. And today we have such an important topic to talk about, which is kind of front and center of all the news and all the families and so many people, just this whole idea of youth mental health. Today, we're going to talk about using CBT and how to use it to treat anxiety and OCD in youth. And we have two amazing people with us today to have this conversation, both Dr. Mona Potter and Dr. Kathryn Boger. So, let's start with Dr. Potter. She's a board-certified child and adolescent psychiatrist with 2 decades of clinical and training experience in the Mass General McLean system. She served as assistant professor in psychiatry at Harvard Medical School and medical director of the Child and Adolescent Outpatient Services, where she helped build several clinical programs and leverage technology to enhance clinical care, including virtual reality for anxiety and OCD exposure therapy. In addition to her passion for improving mental health care, she enjoys summiting mountains, coaching her daughter's soccer team, and keeping the music alive while playing piano duets with her family. That is so cute. I want to learn more about that. Dr. Boger is a board-certified child and adolescent clinical psychologist who has devoted her career to helping children and teens with anxiety and obsessive-compulsive disorder, OCD. She served as an assistant professor in psychology at Harvard Medical School and has published numerous peer-reviewed journal articles, delivered regional and national talks, including a TEDx, and provided training to hospitals, schools, and the community. She is the author of a children's book, Step by Step, about facing fears and being brave. I love it. During their time together at McLean Hospital, Dr. Potter and Dr. Boger co-developed the McLean Anxiety Mastery Program, MAMP. Is there a way to say that? Is it to say like MAMP or just MAMP?
MAMP.
MAMP. I knew there was a way to say it. MAMP, okay? Which is nationally recognized for providing empirically supported intensive anxiety and OCD treatment. And in 2021, they co-founded InStride Health, a specialty treatment program with the mission of increasing access to insurance-backed, research-based care for children, adolescents, and young adults with anxiety and OCD. Boy, do we have two smarty pants with us here today. How cool that you guys worked together and then, so, I mean, you've been working together for a while now, yeah?
Yeah, we've been working together now for over 15 years.
Wow.
My work wife.
Wow, amazing. So you guys co-developed this program and then this intervention, which is incredible. So I'm so excited to learn more about that. And then co-developed InStride, then said, we're going to take this and scale it, take it out on the road. So where did it start from? Like, what inspired you guys to get in this?
Yeah, I guess you could say it started back when Mona and I were first working together on a dual diagnosis residential unit. So we were working with kids who had comorbid substance use disorder and anxiety or depression. And the teens who were coming to us, they felt so broken and lost. Oftentimes they were labeled as delinquents. As we got to know them, though, what we found over and over again was that underlying all of it was anxiety that had been untreated or improperly treated. And their anxiety was just debilitating. And they were just looking for some kind of relief. And they found substances and they found other ineffective ways to try to manage that anxiety. And so we, I think, together became really passionate about helping these kids so that they didn't need to resort to these other behaviors. They had other effective ways to respond to the anxiety.
Yeah, it's kind of one of those things where we realized what these kids, when they get the right treatment, these kids who have anxiety, these kids who have OCD, like they get better. And it's this
Wow.
incredible feeling to go through that journey with them and to see them kind of take their lives back and become students again, become athletes again, become musicians again, rather than feeling like they're these kind of broken human beings. And we were seeing a lot of that at McLean, where kids would come to us, either they had a hard time getting into treatment in the first place, and so things just got worse for them, or they'd been in treatment, but it wasn't quite matched to what they needed. And so they were just getting sicker and sicker. So we know that we have treatment that works. We also know we have a system that's hard to get to. So we wanted to kind of focus our energies on helping these kids and families get that treatment that works.
That is amazing. Do you feel like today it's more prevalent now than it was even when you guys got started?
Yeah. So what we've seen even pre-COVID is that the numbers are just steadily increasing. And, anxiety is the most common pediatric mental health disorder. By the age of 18, 1 in 3 kids will meet criteria for an anxiety disorder, which is really staggering.
Wow. 1 in 8?
What, 1 in 3, nearly
One
one
in
in
three. Wow.
Yeah, that's the lifetime prevalence. If you look
Wow.
at point prevalence, you'll see that it's, according to the CDC, it's 9.4% or 1 in 11 kids and teens have an anxiety diagnosis, which is again a really
Big.
high number. And to the point Mona made before, I think the challenge is we have all these kids who are struggling and a real supply demand issue. It's very hard for the kids who are struggling to access care that is insurance based and that actually has some evidence backing to it.
And I'll say that something that's been kind of striking over the course of like like being a clinician over the last 2 decades is like anxiety's always existed, but what seems to have been happening over time is the kids who are coming in just more severe. Their anxiety is just more debilitating. It's impacting them, their families more. So it's harder to ignore. We're seeing more school avoidant behavior as a result of anxiety, which in my early career, we saw very little of that. So
Wow.
not just that it's more prevalent, it's that it seems to be more debilitating when it's coming up in treatment.
Wow, it's so interesting. All the different reasons why I guess the good thing is there's more of a focus on it now than ever before. People are at least paying attention. So, to kind of frame our conversation for today, we're talking about youth. What's a youth?
Yes. So we're talking about kids, like elementary age kids and teens and young adults. So sort of an age range of 7, let's say, up through 22.
Okay, wow. So that's a pretty big. Now, just out of curiosity, is it very different treating someone who's 21, 22 versus someone who's 7?
Yes. I would say that the same core principles still exist. So, for example, with CBT, it's still the same mechanisms that you are targeting, and you really want to take developmental stage into account. So, when you're working with a 7-year-old who is at home in elementary school, it's a very different approach to engagement than it would be with, let's say, a 19-year-old who's living at college away from their family.
So, when we think about anxiety and OCD, and I guess we're probably going to get to this anyways, but I'm also curious, like, is all OCD, it's all based on an anxiety disorder, or do some people have OCD and it has nothing to do with anxiety? I know people can have anxiety and not OCD.
Yeah. Maybe I'll start and then you
Yeah.
can. So OCD and anxiety used to be, so DSM-4, no, DSM-5. DSM-5 is kind of our diagnostic manual for psychiatry. anxiety and OCD used to be categorized in the same grouping, and it's actually been they've been separated out.
Oh, it's all right.
You're doing great. I threw this one at you too. It's not even on the list. I just figured it probably is later, but
No, this is great.
And so what we see is that, as Kat was saying with anxiety, there are a lot of underlying similar mechanisms, but we're finding is that genetically they look different, and even in kind of how they present, they look different. So for research purposes, they have been separated. That being said, like for treatment purposes, there are a lot of similarities. And what we see is oftentimes kids with OCD will also have a co-occurring anxiety disorder or several anxiety disorders, like a social anxiety, a generalized anxiety. And oftentimes kids with anxiety might also have some obsessive compulsive symptoms, or might also meet criteria. So they can occur together, but they don't have to occur together. They can each come in separately. We've definitely had kids who present just with OCD and only OCD.
it's so interesting. So my father was a child psychiatrist, and he has since passed away, but he always used to say that some people have like a big O and a little C, or a little O and a big C, right? They'd be much more obsessive than compulsive, and some people are more compulsive. So I guess we could get even more granular about it. The symptoms, what do the symptoms look like? And I guess they don't look the same for everybody.
Yeah, but really quickly, it is interesting because, like, when we talk about perfectionism, for example, because we're seeing a lot of perfectionism, and you can say that the part of it can be like there's an obsessive component to that perfectionism. There's also an anxious component to the perfectionism of kind of worrying about your future. So you can see how there's also overlap in how they present. But so, how do symptoms present, or how does anxiety present?
Yeah, and like what might parents or caregivers look for?
Yeah. So anxiety can present in a lot of different ways. What I've been struck by is how physical it can be. And just so it can show up in all parts of your body. That mind-body connection is so strong.
Wow.
And so it can come out through headaches, through stomach aches, through chest pain, nausea, muscle tension, fatigue, restlessness, like shakiness. It can even impact like systems in your body, like your immune system. So oftentimes we'll see kids who've been through multiple medical diagnostic workups looking for kind of the cause of GI pain or the cause of headaches. And there's nothing physically wrong, showing up on the tests. And you realize just how strong the anxiety component is in manifesting these physical symptoms. So oftentimes a kid might show up in a nurse's office or asked to stay home from school due to these physical complaints, when anxiety is a big component of that. And then kind of behaviorally, we talk about fight, flight, freeze of anxiety. Again, it can show up in a bunch of different ways. So the fight is sometimes the one that where anxiety gets masked, where the kid can be so overwhelmed by their anxiety that it comes out in irritability or comes out in anger, when underneath it's really just a lot of fear and a lot of feeling overwhelmed by that fear. The flight is like pretty significant avoidance, where they just kind of, rather than approach something, they might just shut down or kind of not choose not to do it. And the freeze can come out as inflexibility or kind of feeling paralyzed and just really not feeling able to engage in whatever they need to engage in.
Is that one of the things that you guys put together? Because of course we've all heard of fight, flight, but I've never heard of fight, flight, freeze. I love it. Right? Did you add that extra one in there?
I wish we could take credit for that.
It's so good, and I love how you explain that, because I think about, we're talking about youth today, but I think about adults who, act angry, and you kind of have to take that step back and think to yourself, okay, they're anxious. And that's what's creating that behavior. But I guess the earlier that you could help a child with this, or a youth, the better that they're going to be able to manage that as they become adults.
It's such a good point, because we work with families where we're helping the parents identify what mode their child may be in that moment, and then also what mode they're in. And it's about the intersection between the various modes. So I may notice that when I get anxious as a parent, I get in fight mode and my child gets in flight mode, and helping them understand how do those two modes then intersect. And I think that awareness is such an important step toward then actually shifting the response, having some flexibility in like noticing your action urge and doing something maybe a little bit more effective.
So education in this treatment process is part of it. Yeah, like helping people understand those modes.
Yeah, being able to call it out so that you actually know what you're up against. So it is really being able to take that pause and notice before you figure out what you're even going to do about it.
And I think to that point, Mona, the pause, I think, is one of my favorite. I'm gonna call it a skill, but I think it really is an important skill / strategy, because so much of our lives we're operating just on autopilot. We're just in sort of go mode, and to be able to deliberately stop, take stock of sort of like, what are the thoughts going through my head? How am I feeling? And what is my urge to do in this moment? And then actually make a choice in how you want to respond. There's so much power in that.
Wow. So I bet, and you guys have done this now long enough, you've probably really seen, and you mentioned this earlier, people go through the whole cycle and the whole treatment cycle and then get better and get, just feel like they can really thrive in their worlds. What is the gold standard? So what would be what we would consider the gold standard therapy for treating anxiety and OCD in youth?
Gold standard is CBT, so that's cognitive behavioral therapy. We think about CBT as being CBT with a big B, meaning that the behavioral piece is really what is driving the outcomes. And that behavioral piece is exposure. We'll probably talk a lot more about exposure today. But there's also a newer wave of CBT that's called ACT, acceptance and commitment therapy. And this is really focused on changing how a person relates to how they respond to their internal experiences, their thoughts, their action urges, their feelings, kind of like what I was just talking about, so that they can then participate more fully in a life that's based on their values that matters to them.
Okay, so CBT, we hear about this all the time, right? So especially now we have digital CBT apps, and some people do that on their own. What are the core components of it?
The core components, you can think about breaking it down into the CBT triangle. So the thoughts, the feelings, and the behaviors. And the idea here is that each is interconnected, meaning that each affects one another. And the most effective CBT treatment or intervention will target each one of those areas. So targeting the thoughts by being able to catch unhelpful thoughts, check those thoughts, and then change them to come up with more balanced interpretations of the situations, recognizing that thoughts are not fact. Just because we think something doesn't make it true. The feelings, learning how to identify feelings in our body, learning how to manage those feelings, and also tolerate those feelings. I think oftentimes anxiety can feel really aversive, and there's this like tug of war, this urge to like push it away, get rid of it. And so much of it is about learning to ride the wave and be with our feelings. And then the behavioral piece, again, is about exposure. We know that anxiety and avoidance go hand in hand. They're like best friends, and that is a relationship we are trying to break up because it is not an adaptive relationship. The more we avoid, we feel better, right? If I'm afraid of something and I run away from it, I'm going to feel relief in that moment, and it's only going to serve to just grow and grow and grow the anxiety and teach my brain, this is dangerous, you can't handle it. So the idea behind exposure is that in a really structured and gradual manner, we are helping people face the things that they feel afraid of, that they have been avoiding, so that they can retrain their brains to learn that something bad is likely not going to happen. And even if it does, they can handle it. They can manage it. I can walk you through an example. Would that be helpful?
Yeah, I would love it.
Okay, awesome. So let's think about somebody who has emetophobia, which is a fear of vomit. As Mona was talking about before with school avoidance, emetophobia is another thing that we didn't used to see as much, and we're seeing more and more of it. And it's an interesting presentation because on the surface, it sounds like just a specific phobia, just a fear of vomit, but it can actually grow and cause problems in so many different facets of someone's life. Because you could imagine someone who's afraid of vomit, then they start to associate different places they go with the possibility of somebody vomiting. So they start to avoid those places, and then over time their world starts to shrink.
Wow.
So what we do in CBT for a kid who presents with a fear of vomiting? So if you think about the thoughts realm, we're going to help them start to notice and name the thoughts that they're having. So instead of having those thoughts just be their reality, so let's say they're having the thought that I'm going to throw up, or Mona's going to throw up and I can't handle it. I'm going to completely freak out. I will not be able to handle it. That can just feel like your reality. What we're teaching them, though, is to identify that thought and notice that it's a thought, and then come up with other ways to interpret the situation. So like, have you ever thrown up in the past? How many times have you thrown up? Were you able to handle it? Did you ever totally freak out and die when you threw up? Did you live through it? Were you able to manage the situation? What might a friend tell you? And then you're helping them essentially gain some more flexibility in their thinking. They're learning different ways to interpret the same situation. So now you're introducing the flexibility in the thoughts. In the realm of feelings, you're helping them maybe to tolerate their physical sensations. Oftentimes kids with emetophobia, they have physical sensations, maybe like in their stomach. They start to get some butterflies and it's like, oh no, here we go. I'm going to start to get nauseous. Maybe I'm going to throw up. And then it leads them in this whole spiral. So now they're learning to notice and tolerate and sit with those feelings. Maybe they're learning some strategies to help them sit with those feelings. And then in the exposure realm, this is where it gets really fun. There are all sorts of vomit exposures that you can do. I hope, Marjorie, you haven't just eaten, because I'll walk you through.
Thinking about some movie scenes.
Oh yeah. Pitch Perfect is a great one. So you can start at a low level. So start with things like, let's say, talking about vomit. We're going to say the word vomit. We're going to write it down. We're going to watch, as Mona said, some clips. There are all sorts of clips. If you go online, you're going to be careful when you Google it to get the right videos. But there are cartoons of cats vomiting. There's the Pitch Perfect scene of vomit everywhere. Lots of videos kids can watch. And then you can work up. You can work up to making a mixture of fake vomit. And there are different recipes. You can do recipes that you can actually put in your mouth and then vomit it up. You can have the therapist. Oh yeah, no, you can really get into this. You can also listen to videos of or audio clips of gagging sounds of that reflex of somebody who's throwing up. You can take lemon juice and you can gurgle it in your throat to mimic that acidic feeling when you're going to throw up. So all sorts of things that you can do, and then practice to retrain your brain that, again, you can handle it. And we've had kids where we do something called interoceptive exposures, and this targets both the feelings and the action urge, where we are purposely having them get into physical situations that would induce certain feelings so that they can learn to handle it. So we may have them spin in circles. We used to have a tire swing actually outside of our building at MAMP, and we would have kids get on the tire swing and just go in circles around and around and around until they got super, super nauseous. And sometimes they actually would throw up. Other times they would sit there with a nausea and it wouldn't feel fun, and their brains would learn that they could handle it. And importantly, their parents' brains learned that their kids could handle it too, because I think often as a parent, it's very hard to see your kid be in distress.
When you describe it, it makes it sound so cruel.
No, I mean, I think it makes so much sense. I spent many, many years working with the military, and, we used to do something kind of similar, especially if we were kind of reenacting with prolonged exposure therapy, but we would be reenacting something that might have happened in combat, but it could be the smell of gasoline. But so going to the gas station to fill up your car would trigger all of those kinds of those things. And so, or being really close to the train station where the train tracks where like it would vibrate, and we would do similar types of things. But I love the way that you frame it in you're training your brain. You're training your brain that you can handle this. And I have a friend that recently was telling me a story about his daughter who was going to get a COVID vaccine, and she has a fear of shots. And she just had a full-blown panic attack in the doctor's office. And I think you're right. The parents were probably even more freaked out by it than the kid. And so, it kind of then further perpetuates the whole thing, I guess.
Yeah. Kids are constantly looking, especially kids with anxiety, are looking at the world around them for cues on safety. And when they see in their parents this kind of worry, this fear, this unsettlement, that can contribute inadvertently to their anxiety.
And it's also understandable from the parent perspective, because It's horrible
Oh,
when
it
your
is.
child is in distress. There's
So
nothing
hard.
worse. It's the ultimate exposure, right? For your child to be in
Right.
distress and for you to step back and tolerate that and not rescue and not protect.
Yeah.
So what? Yeah, sorry. Yeah.
I was just going to say, so back to where you were saying train your brain, that's where the inhibitory learning model has been like such a really cool concept that we really try to incorporate into our exposures, to kind of supercharge them. And it's this idea that you've got these fear memories that are kind of coded in your brain. And what exposures do is they create new memories for those same cues. And we used to think that when you created these new memories, they would sit on, they would cause the old memories to go away. But what we found is that those old memories they're still coded in there.
Oh,
And so as
wow.
you create these new memories, what you need to do is just repeat over and over and over again. And there are ways in which in that inhibitory learning model that you can just strengthen those new memories. So they become the kind of clear path that your brain relies on.
Wow.
We
Wow. I mean, yeah.
doing exposure life. The idea that like you now, anytime you have the reflex to avoid, you actually find a way to face that thing so that you are continually every single day in your life retraining your brain.
It's so, it feels so revolutionary. Like, just when you think about back in the day, we would just do talk therapy, right? And now it just seems so much more scientific. Um, so I want to know, like, but I want to go backwards for 1 second because I'm curious. But I want to know next. My second piece of this question is what makes CBT more effective than other kind of treatments. But I'm also curious on when we talked about throwing up or the fear of vomiting and the tire swing. Is that a very common one, that symptom that people have, the kids have, the fear of vomiting?
Yeah, we have been seeing it more and more. And interestingly enough, it often presents in kids who haven't thrown up for a very long period of time. So we've worked with so many kids where they'll say, well, I'm 14 now. The last time I threw up, I was 7. And over the last 7 years, this fear has just grown and grown. And
Wow.
yeah.
I think it's a great example of how a little seed of anxiety can grow out of that avoidance and that fear. And so and what we've seen is, I think why it's become an issue is because a lot of kids will stop going to school in context of that,
Ooh.
so that it becomes debilitating because they're worried that they're going to go into school and see somebody throw up or catch a bug that's going to cause them to throw up, then triggers that fear memory, and it just kind of grows and grows, and the more they avoid, the more that fear grows, and it becomes an unhelpful cycle. But that's where the
Wow.
exposure is actually just helping them challenge that thought can really make a difference. The problem is oftentimes we try to have rational conversations with anxiety. We try to give them all the evidence, and I think that's a helpful first step. But what makes CBT so effective, what the research shows us, what we see in clinical practice is actually, as Kat said, that behavioral piece, the actual action part of the CBT. And so it's really showing the brain that what the brain is telling you, what anxiety is telling you, is actually not accurate, and really challenging that by action.
What we often say is you have to live it to know it. Right. So what we'll do before an exposure is have someone identify what are they afraid will happen in the situation? What's their worst case scenario fear? Then we have them do the exposure. And then we ask them, well, what actually did happen? And we compare their anticipatory thoughts to the actuality of what happened. And the greater the discrepancy between those two, the more their brain is learning, the greater the learning in the situation.
Expectancy violation.
Yep.
Wow. This is amazing. I feel like this just it's groundbreaking, I would imagine, for these kids who get to go through it. What happens if like the kid is not uh doesn't participate? Because it really does sound like you need them as your partner through treatment. Do you ever have some that are just resistant and they're like, no, I'm not gonna do it?
Never. At the heart of anxiety is avoidance. So it is like, actually, you could say more par for the course, that they're going to come in and say, I don't want to sit with this. I don't want to tackle this. I'll do it tomorrow is what we hear, or I'll do it later. So it's not even that. Usually they come in wanting something different for their life. They're not happy with how anxiety is hijacking their life. They're not happy with what's happening. They want to feel differently. They want to be able to do all the things. it's also really hard to feel motivated to feel uncomfortable.
And that's where we start at a really low level. So for example, if someone is afraid of vomit, we're not going to say on day one, all right, let's get out the vomit mixture. I want you to put it in your mouth and I want you to spin in circles and feel nauseous at the same time. We're going to start really low level and get buy-in, get mastery as we go. We want them to see like, oh, I can do this thing. I can handle it. I can survive. I'm going to practice it a bunch until I actually get bored, until this doesn't trigger anxiety. And then we're gradually moving up. So over time, their brain is learning over and over, I can handle this. And that said, I would say that so much of what we're doing is finding a way to connect treatment to their values, to make it meaningful to them, so that they're connecting it to what life do I want to live? What matters to me? Who do I want to be? This is not about parent mandated or I'm doing this because I should. It's because I want my life to be different. I want to get back to interacting with my friends because that's something that really matters to me. And most of the time that's really effective. Every once in a while, it's just, there's a kid who's just like, nope, not going to do it. What you say, no matter what you try, this is not happening. And the nice thing is in those situations, we can work with family members. And what we can do with the family members is teach them how to shift the environment so that a kid is living a natural life of exposure. So parents are pulling back on what we call accommodation behaviors so that then kids are needing to still face the things that are scary and hard. If a parent, let's say a child with social anxiety and a parent is speaking up for them every time they're out in public, is ordering for them in restaurants, is talking to other adults or talking to their teachers for them, we're going to teach the parents to slowly pull back on that so that then a child naturally has to do those exposures.
So, and I know I have all these questions and I'm not following the script right now, so I apologize, but I'm so curious about all of this. Is it common that, let's just use your example of the fear is vomiting, and then you do make a lot of strides with that, and therefore that person doesn't have that anymore? Then is there like another symptom that they have? Like, is it usually a one and done, or or does it happen that they on their own start using the same treatments in their head or methodologies in their head to fix some of these other symptoms?
What you're describing is what we call the whack-a-mole phenomenon, where another one pops up.
Anxiety does not go down easily.
Yeah, exactly. But that's where we're really thinking. So we take a transdiagnostic approach, and what we're thinking about is what are the core mechanisms that underlie the various manifestations of anxiety. And so we're targeting, for example, the cognitive inflexibility, the emotional avoidance, the behavioral avoidance, so that when a mole pops up, it's the same approach. And hopefully by targeting across the different moles, then you're kind of keeping them all at bay, if that makes some sense.
Yeah, it does. It does make a lot of sense. So when it comes to this treatment, is it in person? Can you do it virtually? And is the family always there? Or the parents or?
Great question. So as far as the way that we're delivering it at InStride, we're fully virtual. And what we found from the research is that when you compare in person for this patient population, so for example, we published a paper on group-based CBT. And what we found is that the in-person and the virtual led to equivalent outcomes, which is really exciting. It's not true for all patient populations. For this patient population, they respond really well to the virtual model. And I can tell you why. What's really cool is that virtual actually allows you to do exposure work that's harder to do in office. So if you think about it, if you're in office, you have like your 50-minute session, you have your agenda to get through, you may introduce an exposure. It's really hard though to get the kid out in the world engaging with their real life fear. So you may talk about the exposure, you may plan for what they're going to do between sessions. With virtual, a child is out in the world. So we have kids who are in school doing exposure. They have their headphones or their earbuds, their portable device, and their therapist, their coach is in their ear.
Wow.
They do the exposure, or maybe they're in a store or a restaurant, or they're out in their neighborhood doing that exposure. And so their brain in real time is getting to be exposed to different contexts where the anxiety comes up. an example that we can give is, let's say a kid has social anxiety. What you really want them to do is to be out in the world, engaging with other people. We do these things called social cost exposures, where if social anxiety is a fear of being embarrassed or judged, with social cost exposures, we put them in situations where they're purposely going to be embarrassed or judged. So
Ooh.
I know it's, and we as therapists have to be willing to do it ourselves. So we do many social cost exposures. But
And this isn't one of them. I'm teasing.
The idea is that if you can do this thing that's really embarrassing or silly and you're purposefully being embarrassed, your brain gets to learn you can handle it. Nothing horrible is going to happen. So we could have a kid go into a store, for example, a bookstore, and get to the front of the line and pay for their book with pennies. And there's a long line behind them. They're paying with pennies. They're already getting a little flustered and embarrassed. Their coach is in their ear, kind of coaching them through it, checking on what their is. And then we have them drop the pennies. So they're dropping the pennies. Everyone behind them is like, are you kidding me? And the person at the cash register is frustrated too. And they live through it. They see they can handle it. So now all the items that might be below that, like raising their hand in class or talking to an unfamiliar peer, those start to seem less scary and anxiety provoking because they lived through this like really scary thing. So that's an example of something you can do virtually that would be very hard to do in office.
It's great. So you guys can also scale this more, right? You can reach more people that might not be able to get treatment and come if there's, McLean or wherever.
When we were treating fully in person, we were having families drive back and forth 2 hours each way, and these kids have siblings, and then families are having to figure out what to do with the siblings. We had kids and families relocating from across the country, actually from across the world, for the
wow,
which, I mean, great that they could access it, but that's not true for most people. And they're still moving out of their lives to come get treatment. Well, anxiety shrinks your world. It takes you out of your world. Our whole point of treatment is trying to get them back into their world. So rather than pulling them out of their lives into treatment, what we're trying to do is put them into their lives and bring the treatment to them while they're actively engaged in their lives. And that is what the virtual piece helps us do. And it helps us ensure that it's not just the child, but it's also the system, the family, the school, just the people who are actually in it with them.
So what's really cool is kids can access treatment before school. They can access it during the school day, or they can do their full school day and come home and do their sessions. We have parents who log into our parent group in their lunch break or while they're making dinner at home. So again, to Mona's point, they're really integrating treatment around their lives as opposed to treatment getting in the way of their lives.
I'm curious about like assessment and kind of like diagnosing, right? So when you get these kids that come in, and if they're virtual and then you haven't seen them in person or whatnot, is there a beginning stage of this where there's like an assessment, or if what's coming to see you has already been screened somewhere, a pediatrician or another therapist, and like how does that early stage stuff work?
Yeah. So a provider who sends a patient our way likely has already done some sort of screening. They're getting the sense that the child is struggling with anxiety or OCD. And then when a child comes to us, we do a comprehensive evaluation. So we're really understanding the full diagnostic picture and the mechanisms underneath. And then we create a case formulation and develop a treatment plan based on that.
I think one of the things that I've seen happen over like the course of my career in like with kids who've come to us for treatment or when I've done consultation work in schools is that oftentimes we jump very quickly to problem solving and solutioning and skip that initial assessment step or do a kind of a more superficial assessment saying that the assessment will happen over time. But what we miss out on is really being able to be deliberate about kind of understanding what's perpetuating the problem, understanding what targets are, understanding the goals. And so that we do spend a little extra time up front to at least give ourselves that understanding and that rubric. And then we can keep shifting along the way. And so we do use measurement-based care to like really understand, is our intervention working and getting us where we want to go? If not, then let's stop and let's reformulate. but it is really helpful to kind of think through more deliberately. We actually have had the question of like, how important is it to break down the anxiety disorder? So there's anxiety, and then there are kind of all the different ways in which anxiety can present, like panic disorder, social anxiety, separation anxiety, selective mutism, generalized anxiety. And the question is like, how important is it to get precise? And what I've seen and what I've learned kind of over the course of like seeing CBT at its best is that being precise can oftentimes help you decide interceptives are really important to add in here, or the family component, and ensuring that the parents understand this piece of the treatment is really relevant with the perfectionism, for example. So I think that that's where precise diagnostics can really help enhance the treatment as well.
Yeah, I would agree with that, Mona, because we do take a transdiagnostic approach, and specific to exposure, knowing what the anxiety presentation is or the OCD really helps you target the exposures to the fear. And the other point just to make, I just want to build off of one other thing that you said is, so as we're doing our case conceptualization, we're identifying not only, importantly, what are the targets for this child in treatment and what are their associated goals. Because we take a systems-based approach to care, we're identifying also what are the targets for the family and what are their goals. And then what are the targets for school and what are the goals that we have there? So for example, in the case of school avoidance, like what are the things that need to shift in the home environment, what needs to shift in the school environment, and how can we all collaborate together to ensure that the child is getting a surround sound experience?
Well, that leads right into our next kind of subject area about collaboration. Was when you think about the schools, how much, like, how involved is the family?
So I'd say that over the course of our building the program at McLean and InStride, the family component is probably the piece that we built them out the most over time. So we believe it's a very important part. And I'd say that the research backs that up as well. Anxiety is caused by both nature and nurture. So the genetics and the environment are important to consider when you're thinking about the treatment piece of things.
We know you can't treat these kids in a vacuum. And if you try to do that, I think it becomes a real uphill battle.
And then what about the school?
They think the same. They spend so much time at school, and so much of just kind of how they're understanding the world and learning how to interact with the world is at school. And oftentimes what we would see is a kid with anxiety would be sitting in class, start feeling the anxiety, and then go and sit in the nurse's office or the guidance counselor's office. And there's a lot of kindness happening. There's a lot of support, a lot of talk to me about your anxiety. And what happens when they're outside of their class is that they're missing what the teacher's teaching. And they're kind of realizing that if I feel anxious, I just need to go and talk to this person, and then I will feel better momentarily. What that's unfortunately doing is also it's perpetuating the anxiety, in that they're not learning that when the anxiety comes up, it's okay, you can handle it, and it is really important for you to still remain in class and listen to what the teacher is saying. So let's figure out, how do we help you do that? And so being able to work with the schools to kind of to come up with that shared goal. I'd say that the schools are also very much in line with that as well. Everybody wants these kids to be students, and anxiety is uncomfortable for everybody. And so we all want to make them feel better, but it is recognizing that sometimes in order for them to feel better in the long run, they have to be able to tolerate the not feeling so great in the moment.
So right out of the gates, when they first start treatment, do you then bring in the family and the school, or do you like start with is there like a process to this where you get the kid comfortable with how it's going to work and the family's included, and then you slowly bring in school? Or is it just like, let's just do it all at one time? Or does it change from kid to kid?
I think that's part of the formulation. It's part of understanding what are the different components of what's driving the anxiety and what's perpetuating the anxiety. So especially when there's school avoidance, it's really important to get the school and the family on board right away, because the environmental piece is such a major component of what's going to help the kid get back on track.
I think the other consideration there is just stage of development. And so, for
Yeah.
example, when you're working with a younger child, let's say an 8-year-old, you're going to bring in the parent much more quickly and they're going to be more involved than, let's say, when you're working with a 21-year-old who's living away from home.
So what does success look like?
Well, success looks like kids are getting their lives back. I think that when kids come to us, typically their worlds have shrunk. And so we see kids who have essentially fallen off the developmental curve. They're not participating in things that really matter to them because of their anxiety, because of their OCD. So let's say they are not going to school, or they're going to school and they're not going to most of their classes, or they're not doing their schoolwork. They're not interacting with friends and hanging out with them on a Friday night. They're no longer engaging in chess club or playing football because anxiety or OCD is driving the bus. And success can look like kids reclaiming their lives, and importantly, families reclaiming their lives, because many of the families who come to us say that not only the child, but the whole family system can be held hostage by the anxiety or by the OCD. So now all of a sudden, everybody is back in the driver's seat and they feel like the decisions are really being driven by what matters to that kid or that family and not what is dictated by the anxiety or OCD.
Yeah. I'd say it's almost having a different relationship with the anxiety, having a different relationship with the emotions. So the anxiety, we are not looking to get rid of anxiety. There are times when anxiety is very helpful and important to experience.
Look at, I wrote that down. When I made a note because I was going to ask that question.
Yeah. And so it's all, like, all emotions are important. They communicate to us. They tell us something. The problem with anxiety disorders is that the anxiety is sounding false alarms. So really, success is being able to pause when anxiety speaks and to say, hey, let me like assess whether, like, how I'm going to react to you, what am I going to do in response to what you're telling me, rather than just doing whatever the anxiety says to do, or acting in the urges that anxiety brings up.
It's such a good point, Mona. And the treatment that protocol that we have developed is purposefully time limited, because the idea is we are not trying to create perpetual patients. We are trying to help kids be kids, help kids be chess players or football players, help them live their lives. And so we're teaching kids and families this new way of responding to anxiety and OCD, so that then beyond InStride, beyond treatment, they're continuing to perpetuate those gains. They're living that life of exposure. They're learning that when the anxiety comes on strong, that's okay. And they can handle it. They can manage it. And same for their parents. They can handle it. They can manage it. And everybody can kind of ride that wave.
It's kind of fascinating, the whole thing, to me, because you brought up the nature nurture earlier, but how much of this do you think is like they're born this way, or it's their environment that it happened? And then I guess my second part to that question is, if there's environmental factors that have made this, like, contributed to it, is it ever an issue bringing in the family for treatment and involving them? If in some cases, could they be perpetuating these behaviors?
I'd say that I mean, we've got good, like, research that shows that it's both nature and nurture. And so I'll give an example of social anxiety, where babies are not born as blank templates. They're born with all of their genetics, and so they come to the world with kind of their own sense of. They come to the world as themselves. And we see this with siblings, where a parent might approach two siblings in the same way, and one sibling will respond very beautifully to that parenting style, and another might just have a really hard time with that style. So that's where the genetics can, kind of the temperament and what the child brings to the table, can be really important. And what we see with, for example, with social anxiety, is that there's a temperament behavioral inhibition, where some kids are just born more sensitive to the world. And what we find is that how the parent responds to that child can really impact how that gets expressed over time. So not all kids, or not all babies who are born with this behaviorally inhibited temperament, go on to develop social anxiety, but many of them will. And part of what differentiates is that environment and kind of how that interplay between the child and the environment as they're kind of learning how to engage the world. And so that's where and oftentimes, and because there's a genetic component, oftentimes children with anxiety disorders have parents who might be somewhere on the spectrum of anxiety as well.
Mm-hmm.
And that's where we talk about these are skills that are good for everybody to know.
Right.
And so it is. So we at InStride, we have not only groups for our kids and individual sessions for our kids, but also groups for the parents. And we bring the parents into our sessions. And the group for the parents is not only to help them make sure they've got the language we're teaching their child, but also for them to talk to other parents and hear what their experience has been and to have that support. Because it is hard. I mean, we care about these kids. Like, and when you care about somebody, that's where the anxiety spikes the most.
Yeah.
And so it can feel really, really hard. We're
Yeah.
talk about this with each other all the time. I mean, we're anxiety experts, right? We think about anxiety all the time, and we laugh at ourselves when we catch ourselves doing things with our own kids that we're trying to coach parents out of. So it's really hard to do this, and it's hard to do it every day when you're yourself exhausted, when you're pulled in a lot of different directions, and have a lot of competing demands on your own plate.
I love how much empathy you guys both have. Sorry, were you going to say something?
No, I was just going to say that I think that speaking of empathy, it's hard in general to be a parent. It's really hard to be a parent when your child is struggling, and in particular with anxiety or OCD. And so much of what we're asking parents to do is incredibly difficult. It is going against every parental instinct when you are saying to a parent, your child is struggling right now, and I need you to step back. I need you to step back and allow them to struggle through this, allow them to ride the wave so that their brains can learn they can handle it. That is so, so hard. And oftentimes what comes up for parents is a range of emotions. We see a lot of guilt, we see sadness, we see frustration, we see fear. And so we're helping family members identify what comes up for them when they're trying to implement these interventions, and how can they respond differently to the emotions they're experiencing in that moment, as opposed to, again, operating on autopilot.
That's so great. What about medication? We talk a lot about medication. Is that part of treatment?
Yeah. So as a psychiatrist, I will say that my own prescribing style is that I will not prescribe a medication unless there's also some sort of therapeutic or behavioral aspect to what they're doing. Again, part of that retraining the brain and making sure that we're really kind of thinking about changing the relationship to the emotions. And that being said, this is biology, this is nature and nurture. So there is a biological component to it that the medication can really help. So the research shows us that the combination of an SSRI plus CBT is more effective than medication alone or CBT alone. But medication alone and CBT alone have been shown to be equally effective in research. And all of this is more effective than placebo or kind of no treatment. And so how we interpret it in kind of the psychiatry world is if a kid comes in with mild to moderate anxiety or OCD, it's very reasonable to start with CBT as treatment and give that a good try. Hard part is that the CBT is not always available. And so in that case, I think oftentimes some pediatricians, for example, will start an SSRI because there's still some intervention that's actually tackling the anxiety and OCD. When it gets more severe, it is very reasonable to think about the role of medication sooner. Again, just to be able to tackle the anxiety from multiple angles. When I talk about the medication as this medication is on board to help you access your therapy. So we're trying to turn down the volume of that anxiety or turn down the volume of that OCD so that you can actually engage in these exposures. So you're willing and able to do these things, these really hard things that we're asking you to do.
And it makes a lot of sense, especially you're not just saying, here's the pill, right? Here, take an SSRI and I hope for the best. Like you see it more augmenting this treatment that you're doing.
Absolutely. And I would even say kind of allowing for access to that treatment. We also talk about, especially with that teenage brain, I'm like, this is not a permanent medication by any means. So our goal is to allow this to help you access your treatment, the exposure, the CBT work you're doing. As you do that work, your brain is shifting in its response, in how that anxiety plays out. And so our goal is, over time, as you make those shifts, we can take the medication off. So we absolutely talk about the medication as a time limited treatment, again, especially with these teenagers who are coming in, or these children even who come in for treatment.
Yeah, I bet. You mentioned a little bit about, I think you said spectrum, but is there like a level of intensity, right, where some are more mild and some are more intense? And what is like the time? Is it once a week they come in for therapy? Is there a time where that's not enough?
Yeah, so there's absolutely a range when it comes to anxiety. I think it's interesting. People often think of it as binary, like either I have anxiety or I don't. And in reality, there's a full spectrum of acuity. And I think for the more mild presentations, once a week can be sufficient. That can be enough to really move the needle, to introduce the new concepts, to have there be practice between session and the new learning. But when anxiety becomes more moderate and in that severe range, I think it can be hard to get traction with that once a week model. It can be hard to have enough new learning opportunities that the brain is actually getting retrained because of the degree of avoidance and because often of the degree of family accommodation that we see.
I feel like I often say it's like you're learning a new language. So if you're trying to learn French and you go into a French class once a week and sit in a lecture, learn some new words, and then kind of go about your business for the rest of the week until the next class, it's going to take you a long time. I mean, you will learn some French. It's just going to take you a while to actually have your brain like really integrate that new language in. Whereas if you go into that class, learn some things, and then incorporate it in, so you've got people you're practicing it with, you're kind of deliberately thinking about using that language in interactions throughout the week, your brain just has more opportunities to code that new learning, and it's going to start feeling more natural. It's going to start feeling like a new way of being able to communicate and engage.
So, and I can give you an example. So imagine you have a kid who, because of the severity of their anxiety, has been out of school, let's say for a year, and they are spending their days in bed. They're playing video games. They're not seeing friends. They're not doing things that they used to do. And their parents are just like at a loss. Maybe one parent has taken a leave of absence from work to try to manage this situation. Oftentimes that it's going to be an uphill battle, even to get just like that person to click on a screen, right? To be willing to engage in a therapy session, much less to start doing the exposures, to get out of bed, to get out of the room, to get out of the house and back into school, back into life. So the once a week model can feel like it's sort of a drop in the bucket. Whereas when there are multiple touch points a week, so for us, let's say we have, in the beginning, we have therapy sessions, we have coaching, which is both live, multiple coaching sessions a week, and then between session coaching. So their coaches are texting and they're encouraging them. And when they, make the toward move of getting out of bed or going, into their living room, steps toward their goals, their coach is reinforcing that. And then they have groups. So they're around other kids who are also similarly struggling. They're getting that encouragement, that peer support. And then their parents are in a parent group and they have the medication management piece. So really this wraparound care that is helping this kid make real significant movement forward. And then over time, because to the point we made before, we're not trying to create perpetual patients. We want these kids to be kids. So as they are progressing in treatment, now we're removing gradually support so that they can stand on their own 2 feet and they can fill their afternoons with the things that they weren't doing. Now they're back in school. Now they're back in their extracurriculars or they're hanging out with friends. And that's what we want them to be doing because now they're living a life of natural exposure.
That is great. How do you know when it's working? Like is some faster than others?
Oh yeah.
Yep. Definitely. Kids can certainly progress through treatment in different ways and in different paces or at different paces. And so, parents often will say, like, how do I know if treatment is working for my kid? Treatment can feel like it's like this black box. And so one of the things that we'll recommend is that families will collect some data. And so, for example, if their child is doing CBT, there should be very clear treatment goals at the outset. And then you can track the progress toward those goals over time. Ideally, the therapist is doing that tracking and sharing with the family. That doesn't always happen. So in that situation, a parent can also informally track. So if a kid has been avoiding school, a parent can actually track the number of days that they have been attending. They can track the progress toward the goal. Or if a child has been, let's say, avoiding their dance class, they can track the number of dance classes that they're doing. And the idea is to just track and see if functioning is changing over time, if there is progress toward those goals. And then we will often say to family members that it makes sense to set a reevaluation point. So let's say 6 to 8 weeks after the start of therapy, to see if there's been any movement, to see if there's some traction in the treatment. And if they're not seeing any change, that's a good opportunity to check in with the child's therapist.
I'd say that this is something that is a little different in CBT versus kind of a more supportive therapy or a talk therapy, where there are kind of clear goals, and you're using those goals to help you understand if you're making progress in treatment.
How do you know when it's done?
Yeah, so as we said before, we do not want to create perpetual patients. We want kids to be living their lives. And so treatment really should be time limited. And the analogy we like to use is that if someone's hungry, you can hand them a fish, but then every time they're hungry, you got to keep handing them fish and they become reliant on you. Instead, what you can do is hand them a fishing rod and teach them how to fish. And that's what we're doing with kids, with families, with the schools, with any supports in a kid's life. We're handing that rod, we're teaching them how to fish, because then they won't need us in the longer term. They will be able to continue to get those fish on their own. So we're teaching them this new way to respond to anxiety, to OCD. And when they've learned that language and they start to really integrate it into different facets of their lives, and you're seeing that traction, that's when you can start to pull back on the supports and then eventually have kids go off into the world and get those fish on their own.
And I guess, like, before we kind of move over to like tips for therapists, because I do want to make sure we cover that. What do you do when you have, like, not resistant parents, but parents who may not think that the kid doesn't need as much therapy or doesn't need the medication? Like, do you have to make sure you have to make sure the parents are aligned and the kid is the kid is aligned, or if as long as you and the kid are good, it's fine? How does it work?
Yeah, I think it's important to really understand what the parent's concern is. And then once you have a full understanding of what sort of the blockers are, that's when you can collaborate together to figure out the right approach moving forward. So for some families, for example, it may be just logistics concerns, that they have multiple kids, they have jobs. This is one more thing that is just overwhelming their system. And that's where you can kind of put your heads together. That's where virtual can be really beneficial, because treatment, again, can be integrated around a family's life. Other families have concerns about how long treatment is going to take, and what impact this is going to have on their family if their child is in therapy for years and years. Again, that's where like the time limited approach can be helpful. And then I think it's also important too to educate them on what treatment will actually look like. So for us, our kids start more intensive, and then because we're removing supports as we go, that then frees up the family and the child to have more time over the course of treatment. And then again, for other families, the concern really is around the changes they'll have to make in treatment. It's really hard to remove accommodations. It's really hard to do exposure. And so validating that concern and helping them kind of navigate that and manage their own emotions can be helpful.
Thank you so much. Okay, so now I'm going to shift a little bit to tips for therapists. So we have our listeners who are, might be in their private practice somewhere, might be part of a group. Can they do this on their own? If they have a client, do they have to send them off? Or what tips do you have for therapists that are seeing children with anxiety and OCD?
Yeah, having interviewed and met with many therapists over the last 2 decades, I think a pattern that I've seen is that therapists will be doing CBT, but actually exposure is not included in that, or
Interesting.
it's not a big part of that. And I think that makes sense because we go into this field because we are helpers. We want to alleviate other people's distress. And then in exposure, you're purposefully putting somebody in distress, right? And that's really hard. And I can remember the first series of exposures that I did, and kids were crying or they were having panic attacks. I mean, doing interoceptives where purposefully you're inducing a panic attack in a child, and thinking to myself, oh, first of all, my anxiety is through the roof as the therapist, this new therapist doing this. And I'm wondering, like, am I actually doing the right thing? Is this okay? Having done it now multiple hundreds of times, it's really remarkable to see the results and to see the gains that kids can make through this therapy. And so I think that one piece of advice that I would get is to actually really lean in on the exposure element of treatment, and to maybe even if you have some of your own fears, to practice. And so, I myself have had a fear of mice, and I
I
went through.
have that too.
You do too? Oh,
Yes. It's so stupid. I like have to tell myself they're so tiny. Like, and I spend a lot of time in my New York apartment, and there's just mice not in my apartment, but you can walk down the sidewalk, a big old rat or mouse crosses right over you. I'm like,
yes, New York is like flooding for someone who's afraid of mice. But I think it also goes to show that anxiety is not rational. It's like idiosyncratic, and somebody can tell you until they're blue in the face that like they're tiny, they can't hurt you, and it's still encoded in your brain as scary, dangerous. And so for me, it was a very humbling but also helpful experience to practice exposure therapy myself, and to see how A, hard it is, and B, how effective it is. And so I think practicing it on your own and then really making an effort to integrate it into your practice, and you will see real benefits for the kids you work with.
it's funny because I sometimes I'll walk through Central Park and there'll be squirrels, and I say to myself, see, it's a squirrel. It could just be like a rat. It's or a mouse. It's like the same thing with the pretty tail, but you're not afraid of the squirrel.
Anxiety is not rational at times.
Yep.
So yeah,
Is it okay if I add something?
please.
So one thing that we've noticed about anxiety is that that sometimes Kat and I talk about how we wish that anxiety on the more severe end could have a different name, because it oftentimes just gets grouped in where most people feel anxiety to some degree.
Uh-huh.
Well, I think we often think that we can really truly understand what it's like to have that kind of severe anxiety. It's really it can get really debilitating. It can get really overwhelming. And what happens is when treating that kind of more severe anxiety with more talk therapy or just the cognitive part of CBT, it keeps growing. And so I think also is, so if we're kind of talking about what level of care, if we're noticing that the anxiety is starting to shrink the world, it's starting to cause some questioning about going to school, starting to keep the child from engaging in the things, I would say really wonder if once a week therapy or once every other week is enough, or if just doing the cognitive part of it, or just doing a little bit of behavioral is enough, or just doing it with the child, not with the system, is enough. Just really just kind of ask, because it's very treatable, but what we find is when not treated in that systems-based, exposure-based treatment, when it can grow and get more severe, and then you all of a sudden find yourself really stuck and trying to catch up.
I know a handful of kids that I think would really benefit from this. I think it's amazing the work you guys are doing. For therapists who want to get more skills, any advice for them of how to do that or where to do it?
Yeah, lots of opportunities for training for therapists. So one thing that you can do is live training. So for example, the Beck Institute has live CBT training. There are also a plethora of online training. So for example,
Psych Hub.
right there, I'll stop there.
No, it's all good.
Yes, Psych Hub. And I think that when you're practicing CBT, leaning in on all aspects of the triangle. So again, leaning in on the exposure piece in particular, and thinking about how you're incorporating inhibitory learning into the exposures that you're conducting. And then, there's a great book, The Big Book of Exposures. It's by Kristen Springer and David Tolan. And it just has so many awesome ideas for creative exposures. I think when people think about manualized treatment, I think they often see it as this sort of like rote, protocolized, I'm going to follow page 1 and then page 2. And when you're doing CBT for anxiety and OCD, it's such a creative treatment and the exposures are so cool. I mean, I could think of so many incredible exposures our therapists have come up with.
Yeah.
That book is also a nice resource for neat ideas.
But I think that's the point, Kat. It's getting creative and talking to each other. I mean, I think that's what we've really tried to create everywhere we've worked over our career, is that team of people who come together and share ideas and kind of try to think outside of the box. So we talked about like how for the vomit exposure for kids who we cannot get to do anything, we've used VR because they're like, oh, this is a cool new different thing. And then one of our postdoc, he's a postdoc now, a therapist, he actually created vomit videos in his house.
Wow.
And we put it into the VR world, and that's just a way to engage. So it's just thinking
Wow.
about this really serious thing, also kind of fun and creative in our approach.
You guys, this has been amazing. Just to recap, we've talked about CBT as the evidence-based, I like in the beginning you said it research-based too, treatment for youth with anxiety and OCD. We talked a lot about exposure and that's a key piece to this OCD, that medication sometimes can play a role, that it's really important to collaborate with the family and the school in their environment, that you can be creative in the treatment, or let's just say it has flexible guidelines. So there are guidelines to the treatment and it's not ongoing, it's time limited, so that you're not having perpetual patients, which I love because I do think sometimes what's wrong with our field oftentimes is it has reverse incentives sometimes, because you actually don't want people coming in every week ongoing for their best treatment, but that means that then you have a spot to fill and that all of those other things, and it's hard to start the treatment. It's a little bit easier once you build that alliance. And that there's also levels, so that not everybody is at the same level. Some are more intense than others. Did I summarize everything? Did I miss anything?
Beautifully.
Yeah.
No, you got it.
All right. So what is the number one thing, we always end with this, that therapists can take away from this discussion?
Well, I'm an exposure therapist at heart, so mine is that exposure is a key element of CBT and that it's highly amenable to the virtual context.
And I will say that treating pediatric anxiety is a team sport. So kind of that collaboration and coordination across the adults in their lives is important to help build sustainable change.
Oh, you guys are amazing and you're doing great work at InStride. Where can people find out more about the work you're doing?
We have a website, instride.health, probably the best place to go.
And we also have an email, info@instride.health.
Perfect. Thank you so much. I learned so much. So I imagine that all of our listeners have as well.
Thanks for the conversation and for including us in this. It was a lot of fun.
Yeah, this was wonderful. Thanks, Marjorie.
Thanks so much for listening to Therapy Cafe, the future of mental health. For more information and resources regarding today's topic, please take a look at the episode show notes. If you'd like to obtain continuing education as a psychologist, counselor, social worker, or therapist, you can purchase a 1-year subscription to PsychUp's learning platform. Once you're signed up, you'll have access to earn CEs for this and every Therapy Cafe episode. Plus, you'll have access to our existing library of over 100 evidence-based practice continuing education courses created by expert clinicians. Go to psychhub.com/sign up for more information.